This
All right. We will go ahead and get started. So I'm Will Schmeckley. I'm a project coordinator at the Nebraska Medical Association, and I am our sort of host for this morning. Um, you can see on my screen it says Buprenorphine 101, Ed Kaiser. That's not the talk you all signed up for. Stephanie Bennington was supposed to be doing a trauma, PTSD, and substance use disorder talk. She was in a car crash last night. She's doing okay. I talked to her this morning. She said she's doing okay, but she is in the hospital right now, so she is unable to do her talk this morning. So Ed was nice enough and quick enough to with his presentation to be able to have something ready. So Ed is going to do a Bupe 101 talk, which will be great. I'm going to turn it over to him in a minute here. Just get through my usual introduction stuff. So this slide here, disclosure of relationships, it just says that everyone involved in this Project Echo this morning has no relevant financial relationships to disclose. Then our funding statement, we're a grant-funded project. Grant funds come to us from the State Opioid Response Grant, which is a federal grant that is managed by the Nebraska Department of Health and Human Services. So we like to thank our partners at Nebraska DHHS for working with us and the grant funds to help make this project possible. Okay, so I think we might have a few new folks on today, but most people are kind of familiar with our CME certificate process. At the end of the training, there'll be just a brief evaluation survey. A link to that survey will be in the chat. I'll also email that survey out within an hour or two of the training. So you just got to complete a quick survey, and then I will be mailing out. Um, your certificate within a couple of business days after you complete that quick evaluation survey. Pretty easy process. If you have any issues at all, just shoot me an email. If you're on here, you all should have my email. Okay, I like to just give a quick update, a quick introduction of what is Project Echo on our kind of first training in a series. So Echo stands for Extension for Community Health Outcomes. You can have an echo on a variety of topics. Our echo is on substance use disorders and pain. So we do ongoing trainings and consultations for medical providers on a broad array of issues of treating patients with substance use disorders and or pain. We've got a great hub team of 6 experts. One other thing we can do is do consultations outside of trainings. If you have um, patients you are looking for a consult on, get in touch with me, and then I can connect you with one of our appropriate 6 experts. Okay, so we do these echo trainings in cycles of 4. So we'll be going every other week here for the next 8 weeks. And you can see our schedule here. Like I said, today is a different training because of Stephanie Bennington. If you just joined us now, Stephanie Bennington was in a car accident last night. She's okay, but unable to present today. So Ed is doing a buprenorphine 101 talk. I know some people are still joining, so I may just drop that info in the chat here again. Anyway, so yeah, the rest of the series, we've got a guest coming in a couple of weeks talking about intensive outpatient programs. Then we've got a talk on GLP-1 and SUD treatment that Todd and Alex will be doing, and then we'll be ending this echo cycle on some updates on prescribing buprenorphine for pain from John. And so then how this echo works is then we'll be off in September, and then we'll be back in October, November with another new series of 4 trainings. Okay, so I'm going to stop sharing my screen here and let our Echo expert panel introduce themselves. Um, let's see, Alex, would you like to go first?
Morning, Alex Dorick. I do family medicine and part-time HIV work at an underserved federally qualified health center in South Omaha.
Thanks, Alex. And Todd?
Todd Stoll, I'm a psychiatrist. Shout out to Will, who's taken care of this for a long period of time and coordinated things as far as Echo goes.
Thanks,
Thanks,
Todd.
everybody, for joining.
Thank you. Mary?
Good morning, everybody. My name is Mary Ellis. I'm a psychiatric nurse practitioner and attorney here in the state of Nebraska.
Thanks, Mary. And John.
Morning, everybody. I'm John Massey. I'm a pain physician in Lincoln.
Thanks, John. And we had a few people jump on recently, so I'll just say it one more time. Ed Kaiser is filling in for Stephanie today, who was in a car crash last night. Stephanie's okay, but she's unable to talk or unable to do a presentation this morning. So with that, Ed, I'll turn it over to you.
Thanks, Will. Yeah, good morning, everybody. Again, it's always a privilege to be with you guys. And yeah, just getting called up from the bullpen today to do a quick presentation for you. And so don't have to have any of the nerves of the normal presentation. But anyways, really, it is a privilege to be with you. I'm a nurse practitioner in Omaha, Nebraska. Have had the opportunity to really treat patients with opiate use disorder primarily, but other substance use disorders for just over 8 years. And the training that we're going to do today is a training that our company offers, the company that I work for. And so I want to give a quick shout out to Ideal Option. I've been with them for 8 years. They have like multiple site locations in multiple states. I think we have about 70 providers working for Ideal Option right now. And so one of the trainings that we do for all of our new staff is what we call Bup 101. And so it is really just a kind of an overview of buprenorphine and helping understand the treatment of opiate use disorder and how this medication works and some of the other medications. And I do some of these trainings for like different college students and things like that. I'm going to CSM, the College of St. Mary, in a couple of weeks here. And so I really enjoy just getting the opportunity to talk about this. And so I've told stories before, and you've maybe heard them, but one of the stories that I like to tell about Suboxone is from one of the founders of the company. His name was Dr. Allgaier. He was a emergency room physician, and he was doing continuing education. So maybe similar to what you're doing this morning, getting some CME hours, and he was doing the online one back in the day when we needed the X waiver to be able to prescribe buprenorphine. And again, that was like a special training of several hours you had to do. And it has caused a lot of problems with buprenorphine, which we probably talked about before, about people not wanting to prescribe it or not feeling comfortable prescribing it. But anyway, he was doing the training, working in the ER at the same time. Didn't really think much of it, but about 2 or 3 months or weeks later, a DEA agent showed up in his emergency department and was requesting to speak with him. And so the nurses came back and told him that, and he's like, do you guys know what this is about? They're like, well, they said something about some X waiver or something like that. He was like, oh yeah, okay. So goes out and he talks to the DEA agent, and he says, hey, I'm happy to chat with you. I did this training, but I didn't prescribe any Suboxone. I haven't done anything wrong. So what can I do for you? And essentially the agent looked at him in the eyes and he said this. He said, hey, listen, you need to be prescribing this medication because this medication is going to be saving people's lives. And so back then, it was such a mismatch experience for him. Having the DEA say, hey, you need to prescribe this controlled substance because it's going to save people's lives. And so it was sort of born out of that him and his buddy got together and they started, looking into this more, and they started seeing patients. And now, again, over multiple states, they've really helped a lot of different people. And so my hope for you this morning is just that this training is a sort of a helpful review of just kind of the basics. Whenever we're doing trainings for like colleges and stuff, they always like learning objectives or learning outcomes. And so these are kind of the learning objectives for our time together. We're going to compare and contrast some of the different medications for opiate use disorder and describe why buprenorphine is one of the primary medications that's used. We want to understand sort of the different available formulations of buprenorphine for opiate use disorder and sort of appropriate candidates for that. Understand the mechanism of action and pharmacology of buprenorphine. We're talking about some of the mechanics and rationale for the recommended dosing. Really always like to talk about precipitated withdrawal, especially for patients who are struggling with substance use disorder, have a dependence on opiates. initiating on the buprenorphine at times can be a little bit complicated, but if you understand what's going on with the medicine and how precipitated withdrawals work, I think it gives us a lot more confidence in prescribing it. Talk a little bit about some drug-drug interactions, some side effects of buprenorphine that are pretty common, and then a couple of precautions sort of around prescribing buprenorphine. And again, I would just like to say, we're doing trainings on sort of substance use and pain, and a lot of my specialty is really in the substance use disorder. So as I'm talking about prescribing buprenorphine, that's sort of the lane I'm coming from. This is the agenda. You'll see this slide as we go through it, but we'll hit on each one of these points sort of as time allows, and then leave some time for questions if we have it at the end here. So, all right, so let's look at the kind of the options or the medications available for opiate use disorder. Essentially, there's 3 medications available that the FDA has approved for treatment of opiate use disorder. Again, you guys are familiar with this. It's methadone, buprenorphine, and naltrexone. So the main thing I want you to take away from methadone on this slide is just that methadone it's a full agonist. So it turns that water faucet of that dopamine receptor on at like 100%. It's a long-acting molecule, stays in the person's body for, I think, for about 7 days. But essentially, it's a full activation of the mu opiate receptor. Buprenorphine, represented in that second picture there, this is a partial activator. So it activates each one of those opiate receptors in a lesser degree, results in sort of a partial opiate effect. So if I'm saying turning on the faucet, we're turning it on about 30 or 40% versus 100%. And then the final medication is naltrexone. This does not activate the opiate receptor at all. Essentially, it sits on that opiate receptor and sort of blocks anything from getting on there because of its tight affinity to it. And so it does not turn on that opiate receptor. It simply blocks it. This slide sort of compares each one of these medications in just a sort of a simplified version. We do use methadone, or methadone and buprenorphine are both first-line use for opiate use disorder, and naltrexone also can be used, although I use it more for alcohol use than we do for opiate use. The mechanism of action, we kind of talked about that already. Again, both methadone and buprenorphine, essentially what they do is they suppress withdrawal symptoms so patients can feel normal, and then they also help with cravings. Naltrexone can help reduce cravings, and it definitely blocks the effects of opiates if people use opiates on top of those. There's a little bit more concern about drug-drug interactions with methadone. There are some concerns about QT prolongation and respiratory depression, just because it's a full agonist and a longer-acting one. There is some concerns around that. Fewer serious adverse drug reactions with buprenorphine. We'll look at some of those going on. And then naltrexone is contraindicated with current opiate use. And I threw in there kratom and 7-OH because those are some of the newer ones that are out there. And then as well as buprenorphine. So again, if people are actively using opiates, if they take naltrexone, that blocking component is going to put them into precipitated withdrawals. And then some information just on breastfeeding and pregnancy, both methadone and buprenorphine are first line for those options as well. This one kind of describes the advantages and disadvantages of each of these kind of based on their mechanism of action. So one of the best advantages of methadone that we see is that it can achieve a greater receptor activation for heavy opiate users. So buprenorphine, we'll talk about later, it has sort of a ceiling effect where there's only so many opiate receptors in our brain, and if we turn them all on at 40%, we can't get any more dopamine activation from buprenorphine. But with methadone, we can turn on those at a higher percentage, and so we can get greater activation. And sometimes for patients that can't stabilize on buprenorphine, methadone would be a good option in that situation. There is no risk of precipitated withdrawal when patients start methadone, and so that's a definite advantage of that. Some of the disadvantages of methadone, higher abuse potential, less favorable safety profile. There are some drug-drug interactions. And we talked about increased concerns for CNS depression. It generally, one of the probably the biggest disadvantage of methadone right now is that you do have to be in a sort of methadone, clinic generally, or you have to get daily dosing. I think you can get some take home, but the access to treatment of methadone can be even more restrictive for a lot of individuals. As far as buprenorphine goes, advantages: less abuse potential, more favorable safety profile. We still get this we get this opiate blockade component, which we'll talk about more as we go along. Less drug-drug interactions. Again, these medications, as you know, can be prescribed through pharmacies. All of our patients at Ideal Option are doing at-home inductions onto buprenorphine, so they can take these medications at home. And then it is available both in a sublingual, which is probably the most common, as well as some of the newer injectable forms of medication. Again, the biggest disadvantage, in my opinion, of buprenorphine is just the potential for precipitated withdrawals. And so, again, it does take a little bit of education, I guess, say, for the patients, depending on what they're using and how they're using it to start on this. There are some interactions that are concerning for CNS depressants, specifically alcohol and benzodiazepines, sometimes gabapentin. As we add more of those medications, patients can get increased sedation from that. And then, because it's a medicine that's sent to the pharmacy and people take home, there is a increased risk of diversion or sharing of this medication. It's interesting on the diversion front. There's a lot of information about there that a lot of people that are diverting this medication are using it when they're actually in withdrawals and sort of needing something, and that's how some people get introduced to it. Now, obviously, there's things about diversion that are not good, and people are probably getting started on Suboxone and using and abusing that as well. But the diversion side of it, the studies on it are kind of interesting. Naltrexone advantages: no physical dependence. So again, if you're on methadone or buprenorphine, you are going to have a dependency on these medications as well. No abuse potential, no significant drug-drug interactions. It is available as a oral medication as well as an IM injection. Some of the downsides of naltrexone: it does require about 7 to 10 days of abstinence from opiates before you can start naltrexone. It doesn't treat withdrawal symptoms, so that's a problem. It is associated with sort of lower retention in treatment. And then there is a potential for precipitated withdrawals if people take naltrexone too early. And then the risk of fatal overdose after discontinuing treatment. So again, back in the day, I think as we used to think about substance use disorders, we would, at least before I started in the field, I'd say why don't we just send people to rehab, get them sort of dried out or off of the dependence of the medication. And then I think at that point, we sort of thought we were treating patients' substance use disorders that way. But again, what was happening sort of in the fentanyl era was that we would send people to treatment. We would get them off of the opiates. Their body would no longer be physically dependent on it, but we didn't treat sort of the underlying disease process and what was going on in their brains and how they would be in an environment and be triggered to use substances again. And so even if we had them on naltrexone or gave them Vivitrol, once that wore off, and if they weren't taking their medication, they would get back into an environment. They would use an amount of opiates that was maybe similar to what they use or maybe less, but they were still overdosing from that. And so it really wasn't helping sort of treat the underlying problem. And so again, there is a place for naltrexone, and I do have I've seen a few patients over time that have done well on it for a long period of time for opiate use disorder. But those are some of the risks I always tell people if they're weaning off Suboxone and they do end up using a naltrexone at that point to just prevent overdose, just understanding that without some sort of blocker in there, if they go back to use it, it can be pretty dangerous. Okay, one of the things we do when we do these trainings for the college is sort of knowledge checks. So I'll just go through these with you as we go. But which pharmacological property of buprenorphine makes it preferable to methadone for treatment in the outpatient setting? And our answer to that is that buprenorphine is a partial opiate receptor, where methadone is a full opiate receptor relative to methadone. Decreased abuse potential, improved safety profile, and then fewer drug-drug interactions. And then it also does provide this opiate blockade at the mu opiate receptor as well. All right, so we're going into fast facts. I I see a few things on the chat. I don't know if you want to at each thing like do questions or if you want me to keep going, but I always have trouble monitoring the chat while I'm talking.
Yeah, we have Denise has a case, so maybe if you want to save time kind of towards the end, we can bring Denise's case up and kind of the whole Echo team can discuss that at the end. Does that sound okay?
Yeah, definitely. I
Okay,
can give us 15 minutes or so, if that's okay. I'll try to speed
perfect.
through some of it. You bet.
Great.
Okay, thank you. So let's go into some of just the fast facts about buprenorphine. So again, FDA-approved medication for opiate dependence and chronic severe pain. Formulations, sometimes helpful. So formulations for opiate use disorder, buprenorphine comes in a mono product, means it's just buprenorphine. There's no naloxone added. There's a generic form of it. There's Subutex, and then there's the injectable forms of this, which are Sublocade and Brixadi. Again, both sub-Q injections. And then the combination product, which is buprenorphine with the naloxone, generic film strip, as well as tablet. And the Suboxone just comes in a film strip form. And then Zubsolv is another brand that comes only in tablets. And then the formulations for chronic severe pain, again, this is sort of outside of my specialty, but the Belbuca and the Butrans, from what I understand, there's not a buprenorphine that is FDA approved for sort of acute pain at this point. I think there may be like an IV or an IM one, but nothing that I've ever seen actually used. So as far as the doses that are available of the combo product, generally it's 2 milligrams, 4 milligrams, 8 milligrams, and 12 milligrams in the film strip. The tablets come in just 2 and 8 milligram forms. And then that's the generic, and then the Suboxone is the same. The Zubsolv combo product in the middle there, it lists the dosing on the tablets on the right. So for example, I think the 11.4 is equivalent to like 16 milligrams. I know that the 5.7 is equivalent to 8 milligrams. And so sometimes patients will be having a reaction to the one of the generic or the name brand. And so sometimes we'll switch them over to a combo product of Zubsolv. And I always just like to tell patients when I do that, like, hey, the milligram is going to say 5.7, you're on 8 milligrams a day. Just know that that's a dose equivalent. We're not giving you less medication, because oftentimes they'll think like, oh, I don't feel as good because this isn't as much medication. As far as just the mono product, which is just the buprenorphine, it just comes in 2 and 8 milligram tablets. And then the Sublocade and the Brixadi injections. I think I have a slide on that in just oh yeah, here's a couple slides. So a little bit about Sublocade. It's a monthly injection, FDA approved in 2017, and it's indicated for the treatment of moderate to severe opiate use disorder for patients that are already sort of stabilized on buprenorphine. Dosing of this is 300 milligrams initially, recommended for the first 2 months, and then down to 100 milligrams after that. We do have a lot of patients that are on Sublocade that have a higher sort of dependency on opiates, and they end up staying on the 300 milligram injections sort of throughout treatment. We never go down to the 100. Again, not getting too far into this, but when we initiate patients, we will give them some sublingual buprenorphine on top of the injection if they need it during some of these initiation phases. Brixadi is sort of the newer injectable that's on the market, approved in 2023, and again, indicated for patients who have initiated treatment with a single dose of buprenorphine product or already being treated with buprenorphine. So there's some advantages of Brixadi, in my opinion. It's a smaller needle. It's a lot smaller amount of medication that's injected, and so a lot less painful for the individuals. And this does come in both a weekly injection as well as a monthly injection, and it has some different dosing options with it as well. So the recommendation is to do 4 weeks, 4 injections of weekly, and then at that point you can transition individuals to monthly. I'll talk about it here at the end if we get to it, but we do some direct to inject with Brixadi, which just means is if somebody's tolerated buprenorphine before, but they're very unstable in treatment, meaning they're not coming to their appointments, they're not taking their medicine on a regular basis, they have some issues getting to the clinic, or they're living in a situation, what we're doing is having them wait about 6 hours from their last fentanyl use, and then we're actually giving them a weekly injection of buprenorphine, as well as like some withdrawal medication. So we're just initiating them on the medication that way. And I found a lot of success in people who struggle with the precipitated withdrawals, or just because of their life circumstances have trouble sort of making it to the clinic on a regular basis. Another advantage of these injectables, a lot of the conversations that people have initially, is that if they're new to buprenorphine, or even prescribers are like, hey, how long are we going to be on treatment, and how do we get off of treatment? And patients, after they've been stable for a few years, oftentimes don't want to be on buprenorphine for the rest of their life. And so they can do a slow taper off of buprenorphine, but also a lot of times we will try to switch people over to an injectable, give them a few injections on the monthly, and then that medication will sort of leave their system more slowly and more gradually, and that can help sort of prevent precipitated withdrawals for the individuals. So it's interesting. Some of the studies show that, that stuff stays in their system for even up to like 3 to 6 months. And so just want patients to be mindful of that. This is just sort of the dose equivalence with the Brixadi. Of the left side is daily dosing of buprenorphine and what patients on, or what they'll sort of stabilize, likely stabilize on in a weekly as well as a monthly equivalent of that. I did have a chance. I'm a full telemedicine guy right now, but I did have a chance to go to Arkansas to cover one of our clinics about a month ago, and gave both the Sublocade and the Brixadi, and yeah, the Brixadi was very, very simple injection to give. So one of the common questions when I'm talking to patients about their being on the medication and how to dose the medication is why is buprenorphine taken in a sort of a sublingual way instead of like a sort of a normal pill that you just swallow all the time? And so the main reason for it is the bioavailability. So if you just swallow buprenorphine, less than sort of 10% of this gets into the system. When you take it sublingually and sort of hold it in your mouth and allow it to absorb, 30 to 35% of the medication gets absorbed. And then if somebody would take buprenorphine product and inject it, 100% of that obviously would get activated into the system. So I always like to talk about naltrexone versus naloxone. My son, a couple of years ago, he was diagnosed with dyslexia, and so when I was first working in Ideal Option and I was trying to learn this stuff, and naltrexone and naloxone, they both looked exactly the same to me, and I often got them mixed up. And so I think I realized I have a little bit of dyslexia myself. But the naltrexone is the long-acting opiate receptor antagonist. So the blocking component, again, we talked about it for opiate, but also for alcohol use disorder, comes in a pill form and an IM injection. And then the naloxone is the short-acting opiate receptor antagonist. So we use naloxone, or another name is Narcan, for opiate overdose. This is what we think of when we think about the nasal spray. And this does come in both a IM and an IV formulation. So the question that we're asking, and that patients often ask, and that we talk about with students, is, hey, why is naloxone added to this medication? And really, it's a very simple reason. There's just one reason that naloxone is added to this combination product, and the naloxone is added to really prevent a deterrent, or to be a deterrent for misuse through IV injection or nasal inhalation of the actual buprenorphine. So individuals who snort buprenorphine or inject buprenorphine combination product theoretically should not experience any of the effects of the buprenorphine due to the high affinity of the naloxone, or the blocking component. And essentially, it's supposed to sort of put them into a withdrawal state if they do that. So again, at the bottom of the page there, if you just take a Suboxone pill, a buprenorphine combination with naloxone, 1 to 2% is absorbed sublingually, less than 5% is absorbed. And then if somebody does like snort this or if they inject it, then a larger amount of this naloxone gets activated. And the way that they described it to me is that like in the small amounts, it doesn't cross the blood-brain barrier, but if the intranasal IV way, it can cross that barrier and it can activate that and block that opiate receptor. I have had patients who have been honest enough to tell me that they do inject the combination product and their experience of it, which makes a little bit of sense to me, but have just said that like, hey, the initial doesn't feel great because the naloxone kind of blocks things, but that is a very short acting thing. The buprenorphine is longer. And so again, people are going to figure out ways to abuse medications, but it is a helpful deterrent for being able to prescribe it in the outpatient setting. As far as like formulary selections for individuals, majority of the patients that we're going to see for opiate use disorder are going to be placed on the combination product. We are probably more strict than most on not wanting to just prescribe the mono product due to the concerns of abuse of that medication. But the other rationale is that it is low cost. It's on a lot of Medicaid formularies, and there is, again, lower diversion risk. I do think that the mono product has probably a higher value for diversion. A lot of just like the common side effects of buprenorphine, so headache, nausea, vomiting. There is some peripheral edema that you'll see periodically. Some of the things that we've told our patients that seem to help a little bit. If they're having significant side effects with one of the products, we can switch to either a tablet or a film strip. There's different generic manufacturers, and so sometimes people end up enjoying one versus the other. We can also go to a Sublocade or Brixadi if there's problems with the naloxone. And then adverse drug effects associated with some products, switching to Zubsolv has been helpful for individuals as well. If a patient does have a hypersensitivity to the combo product, then we can switch over to the mono product, or we would encourage these individuals to go with an injectable form. That way we are confident that there's not any diversion going on. And then for pregnant patients, combination products is safe. For a long time, we only did the mono product in pregnant patients, but it is safe to do the combo product and also safe in breastfeeding as well. Okay, who can take it and who cannot take it? Again, people can take buprenorphine from if they have a diagnosis of opiate use disorder, including pregnant patients, as well as adolescents. If there's a history of overdose, if an individual is physically dependent on an opiate, and then if they can also take buprenorphine if they're abstinent and at a risk of return to use. So I think that's important to think about, especially for somebody who's been in recovery for a while and maybe they had a problem with fentanyl or whatever opiate. They've been on Suboxone for several years. They've actually weaned themselves off of it. They've done well for a few years, but now their life circumstances are changing. They're in a more stressful environment. They're concerned about having a return to use. Those individuals, essentially, if they have had a positive, diagnosis for opiate use disorder at any period, any 12-month period in their life, it still is indicated to initiate these patients onto buprenorphine again to really help stabilize them and prevent a return to use. And then essentially who can't take buprenorphine if they have a documented hypersensitivity to buprenorphine, and then if a patient is currently on naltrexone or Vivitrol, we would have to have a washout period of that before they could start the buprenorphine. I'm not going to spend a ton of time on this slide. This is just the DSM-5 criteria, simple questions about opiate use, yes, no answers. And as long as they have 2 yes answers, they qualify for a mild diagnosis of opiate use disorder. It's kind of a hot topic, especially for people that don't maybe fully understand buprenorphine or the treatment of how we view substance use disorder as a disease process. And so a lot of the questions I get initially right away, and especially now with we talked about the 7-OH. So I'm seeing a lot of new patients that are using 7-OH who really don't have a significantly long history of opiate use disorder, but have been using this for 6 to 12 months. They want to know, like, hey, how long am I going to have to be on this medication, and what's the duration of treatment? And essentially in 2020, ASAM was just saying there's limited research, but longer durations of treatment results are better outcomes, and generally that is true. We recommend, that people stay on buprenorphine unless the medication is causing them harm, or unless they're making an informed decision to sort of self-taper off of it. ASAM sort of 2024 considerations, initiation, engagement, and retention and treatment are critical factors that impact long-term outcomes for substance use disorders. Early treatment engagement and longer duration of treatment predicts better clinical outcomes. So again, I always tell patients, like, hey, our goal is to help you accomplish your goals and to keep you safe. And if you want to wean off of this medication at any point, we're going to help you do that, as long as you're aware of the risks. But again, we shouldn't just be taking a medication away from somebody because they're doing well and they're stable. That's sort of against all the ways that we would treat other chronic conditions for an individual that's stable. Okay, knowledge check. Why is the combination product preferred over the mono product? Again, it has the naloxone deterrent for misuse via IV injection or nasal inhalation, so lower risk of diversion. I'm going to spend just a couple of minutes on how to take, or how buprenorphine actually works, and then we're going to kind of push pause on this and do the case study. And then if we get to more of it today, that's great. If not, that's fine. We can make the slides available to you. So again, mechanism of action, we've talked about this a little bit already, but there's few just sort of cool components to buprenorphine and how it works for individuals. So partial activation, incomplete binding of the opiate receptor. I mentioned this earlier, where it kind of turns it on at 40% versus 100%. One of the really cool things about buprenorphine that allows it to have this blocking component is that it has this higher affinity for the mu opiate receptor. So essentially you have the receptor in your brain, and when you get Suboxone in there, it sits on there really, really tightly. And so in this sort of picture on the right, the green sphere is a sort of full agonist, so think oxycodone or fentanyl or whatever. When that's on that receptor, you're getting sort of that full 100% activation of that opiate receptor. But once you introduce buprenorphine into the system with that, it's that buprenorphine is going to remove that and sit on that receptor. And so again, that once we get buprenorphine into somebody's system, if they do have a return to fentanyl use, very much there's a significant reduction, if not zero, chance of them going to overdose on fentanyl if they have a return to fentanyl use while they have the buprenorphine in there, because that fentanyl just cannot get on that opiate receptor and activate it. So again, that's sort of with some of the precipitated withdrawals as well. But the other cool thing, again, is this maximum of 40% activation is this ceiling effect of buprenorphine. And so on what you're looking at in this picture is sort of on the left side of the graph, it's the intensity of opiate effects as we go up. And then on the bottom, it's the dosage as that increases. So if you increase the dose of heroin or fentanyl or oxycodone, as you go higher and higher and higher, you get increased opiate activation, increased central nervous system depression, and eventually that's where people cross over this threshold of overdose and they stop breathing. And really what is most dangerous about the fentanyl epidemic that we're in. Again, the nice thing about buprenorphine is, especially for somebody who has a true opiate use disorder, as we increase this dose of buprenorphine from 4 to 8 to 16 to 24, which is generally the maximum dose, you see how that opiate effect just sort of like straightens out. And so again, I can prescribe a week's worth of buprenorphine for an individual, and that individual could take their whole prescription on day one, and I'm not concerned about them overdosing because it's going to get into a sort of a maximum amount of activation of that opiate receptor. And again, I'm sure patients try to take more medication and sort of realize that it doesn't really help them, but the ceiling effect, especially in the work I do, makes me feel a lot more comfortable about prescribing this medication at home. Kind of skip through we'll do it real quick. True, false. The ceiling effect of buprenorphine, even at high doses, reduce the risk of respiratory depression relative to full opiates. The answer to that is yes. All right, so again, back to the agenda. We can talk about dosing. We maybe should talk about precipitated withdrawals, but we can do that at another time. But I do want to push pause here at this moment, and let's do the case study and kind of see where that goes, and I'll fill in the time as we need to. Does that sound okay, Will?
Yeah, that's great. Thanks, Ed. Okay, so Denise, appreciate you bringing forward this case. It's great when we get to discuss cases on the echo. That information is in the chat, and I won't read through it, but if folks want to check the chat and they can read about Denise's case of a 46-year-old female. Now, John jumped in on the chat about the patient being a candidate for buprenorphine for pain. So, John, would you, if you're still on with us here, John, would you like to discuss that a little bit?
And I don't mind just giving you like a brief so people don't have to translate. I can give you a quick,
Yeah.
So this was just really timely, and I would have, if I'd had time to call the team, I would have called them on this one. But so this young lady came in this week with she'd been had prescribed oxycodone for a couple of years. They just increased her to 10s. And she got a 90-day supply, went through them in about 2 weeks, just chronic low back pain, and was ready to talk about getting off the opioids. So she has a pretty significant mental health history with some psychogenic seizures, grief, separated from her husband recently, and she was in withdrawal whenever she got to me. So we started her on the strips, just 2 milligrams twice a day. And then over the last couple of days, talked about how she can, we talked initially about how to cut them and microdose them, but she was just more comfortable with having just 2 to 3 doses a day. So that's where we are right now. But my main question is about some of those maybe activation symptoms, and then her back pain, just her fear of that coming back, and just how I can best treat her for that.
This is really a great question. Will, is it all right if I just kind of step in here?
Yeah, please do.
Okay. So there's some features here that you've identified and are really probably critical in figuring out where to go forward. And the thing that's interesting is she's taking all that oxycodone in an attempt to mitigate pain symptoms, right? And she's obviously not getting anywhere with that because she just takes that big dose and goes forward. And the overriding issue is probably behavioral and all those other things that you know as well. And this is where we make the mistake. We use a little bit of opioids and they don't work, and we use a little bit more, and then the patient uses a whole lot more, and it's not making her better. The buprenorphine is still going to be very, very important in the management of a pain condition alone, only because it's going to reset those receptors, and it's going to kind of allow her neurotransmitters within her CNS to get back to normal. And the problem is, and this will work for her pain way better than anything else would, but the problem is the time frame and the expectation of the patient, because we have this idea that if you take oxycodone, you're going to feel better right away, because if you break your leg, it will do it that way. But in a chronic pain situation, it's going to improve things at the speed at which other treatments can be effective. And that's like, if you start somebody on an antidepressant, you're not going to expect them to say the next day, oh, thanks, I feel better, right? You need time. And so all of those issues with the jittery and et cetera, are manifestations probably of all of the discombobulation of the neurotransmitters that has been going on because of her index disease, as well as her chronic pain, and notably the treatment she's giving herself with the high doses of the oxycodone. So what I would say in a situation like that is the switch to buprenorphine is an important first step. It's going to make it possible for other things to work. And now you said about making those other things to work at the right pace, and the side effects you manage as you can so that she stays with the treatment. And essentially what we're probably going to find is that there's not a big anatomical reason for her low back pain. If there is, that's something that would be amenable to treatment by any competent provider. But the main risk here is that she's probably got a tendency to display psychological stress into physical symptoms, and that is, as you know, comes along with trauma and all those things that happened to her as an adolescent. So this is where you really need the team to be kind of thinking about the process, going gradually with the changes, and don't let her talk herself out of buprenorphine, because there's no chance she'll feel better on a classic opioid. That will prevent anything else from working, what you're doing and what a pain doctor or somebody else would do. Does that answer make sense to answer?
Yeah,
I think the question.
you know, I can tell you know the patient well, even though you don't know the patient, right? Because she is already asking, you know, when she can get off of it, you know, and I knew it's
Yeah.
good, you know, so we're,
Yeah.
I guess I didn't know if there's any just adjuncts we could add
Sure.
that help.
There is, but just remember, nothing you use is really going to work except if it keeps the patient engaged in the process. If we could think of something that you could just get this patient to say, let's visit again in 8 weeks, now anything is going to work. So, you know, if you want to try something fancy, Jernavix is a new medication indicated for acute pain. It's got no adverse effects for this. It's probably not going to be effective, but it's also going to be well tolerated. And it's very simple to prescribe. It's 2 pills to start and 1 every 12 hours for acute pain. It's basically a sodium channel blocker, and it's as effective as opioids, but without any of that effect. But I would probably de-emphasize medications as much as you can, and then, you know, anxiolytics or whatever is sustainable, and then set about getting a little bit of imaging in a little bit. What I typically say to somebody is, I have to kind of define this a little bit better. Let's kind of scrape this down and get it a smaller problem and see if we can locate it. If you can get her to say, let's wait a month, see where you are, tell me how you do a month after the buprenorphine is in your system. It'll be narrower. She may have back pain when she sits. She may have leg pain when she walks, et cetera, et cetera. Now you can focus in on a small piece of this that's probably anatomic. But don't let her get scared off by the lack of upfront efficacy. And really, that's probably just passive dependence, right? And so if you can find a way to explain that in a fashion that she'll understand, or, you know, not be put off by, you're better ahead.
That's perfect. That's just what I needed to hear. Thank you so much.
Yeah, nice job. You identified everything.
Well, thank you. Anything else, Denise, on this patient?
Nope, I think that's helpful. It was I'm used to I help in with a treatment center where people who get opioids off the street have just these abundant. So it's kind of easier to maintain actually than these nuanced cases where you have prescribed and it's you know it's just a little trickier. So and more focused on that mental focus on the pain. Yeah, it's been interesting, but thank you so much for your help.
Great, thank you. So we've got 10 minutes. Ed, you can I don't see any other questions in the chat right now. So Ed, you can kind of take us where you want to go.
Yeah, thanks. And thanks again, Denise, for jumping in and throwing in the case studies. I think that's one of the best ways, honestly, that we learn is working through those things. Yeah, so let's just cover a couple more topics in our last 10 minutes. Just briefly, we'll go over the dosing, and then I do want to talk about precipitated withdrawals. And then we're really pretty much through most of this. So how is buprenorphine taken? So in the work that we do, the recommendation is once daily dosing is how the medicine is designed. It has a long half-life, 24 to 48 or 42 hours. Onset is about 30 to 60 minutes. That's helpful to know when patients are having side effects and things like that. It does peak about 1 to 4 hours. The sublingual film strips and the tablets, they can all be cut using scissors or pill cutters. And that it is important that patients are sort of dosing this correctly to really get the best absorption of the medication. We have the ability to do sort of mass spectrometer testing, so we can see the levels of the medication for individuals. And a lot of times if patients have been on Suboxone for a little bit of time, and they start to feel like it's not working for them all of a sudden, generally that is not generally, but one of the things is a dosing issue for that. Now, as far as split dosing, split dosing is much more common for patients who have pain. And if somebody I'm seeing has opiate use disorder and chronic pain, I'll often encourage them to split that dose, 2 to 3, sometimes even 4 times a day, although that gets a little bit cumbersome with how many times you got to take the dosing. But patient populations, pregnancy, especially towards the end of pregnancy, patients need higher levels of buprenorphine because of the metabolism and the water volume. And so splitting the dose or increasing it can be important. Again, short-term sort of acute or post-op pain management, oftentimes, and again, this is a little bit outside of my specialty, but a lot of times when patients are on Suboxone, they're going in for sort of an outpatient treatment. We will either have them split their dose up more often, or we'll just increase that dose and split it up more often. The way that I understand it is the analgesic effects of buprenorphine are around like sort of the 6 to 8 hour mark, where again, this medicine is sort of staying in this patient's system longer. It's also okay to have patients that just prefer dosing the medication twice a day. Again, the medicine is long acting. It does kind of build up in their system, but if a patient prefers to take it twice a day, that's fine. I do try to push patients away from, it's like sometimes you get patients that take like a very tiny amount of Suboxone, like kind of all day long, just sort of whenever they need it. And when we're talking about sort of substance use and sort of a pattern of like taking something when there's a life stressor or something difficult that happens, I do try to encourage patients not to take it like that, but to take it at a sort of a set time throughout the day, no matter how they feel, as long as they're not having negative side effects. I want them to sort of take the medication on a regular basis. This is the dosing sheet. This is a patient-facing handout that we give people. And really just the main call-outs that I encourage patients with when I'm talking to them is no eating, drinking, smoking, but really no vaping or no nicotine products 30 minutes prior to dosing this medication. The nicotine causes a vasoconstriction, and it really, in our experience, affects how well the medication can be absorbed. I tell people if their mouth is dry, take a warm sip of water, put the medication underneath your tongue, try to hold the medication and the saliva in your mouth until that medication is fully dissolved. For most individuals, that's about 5 to 15 minutes. We do recommend spitting the medication out afterwards. If a patient chooses to swallow the medication, sometimes it's associated with some side effects. It's not going to hurt the patient in any way, but they're not. I just always like to really hammer home, like, hey, the absorption happens in your mouth, not what you swallow. You're not getting a significant amount of that medicine absorbed. And then afterwards, it's okay to go back to eating and drinking and smoking if you prefer. We do recommend that patients brush their teeth an hour after dosing this medication. There's been some long-term data around cavities and sort of dental issues with long-term use of buprenorphine. So we're just encouraging patients to really do good dental hygiene. Kind of called this out already, but the nicotine products is important. Maybe avoiding sort of cloudy liquids in coffee due to the change in the pH. But again, just 30 minutes ahead of time is generally pretty good. I'm going to skip your knowledge question. Just want to touch base on precipitated withdrawals real quick before we kind of end our time together. So essentially, like, what is precipitated withdrawals? And again, it's a condition where when an individual is on an agonist like methadone or heroin or fentanyl, when that is displaced or removed by a antagonist or a partial agonist like buprenorphine. So when I'm talking to my patients, I'm like, hey, your body is at a dopamine level requirement of this. And if I introduce buprenorphine and it removes fentanyl from that receptor, that dopamine level is going to drop really drastically. And with that significant fast drop in dopamine, that's where you get this, what's called precipitated withdrawals, which is just the most severe withdrawal symptoms you can imagine, but it happens all at once. It's not gradual. A lot of patients who have tried buprenorphine on the street have put themselves into precipitated withdrawal, and the way they describe it is it's probably one of the worst experiences of their life. So the signs and symptoms similar to spontaneous withdrawal, just much more severe. Again, can occur about 30 to 90 minutes after the initiation of the buprenorphine, and it can last a long time if we don't treat it appropriately. This is probably the most helpful slide that we do with what's going on with precipitated withdrawals and how to overcome them. So essentially, as you look at this little graph here, with low doses of Suboxone, like this is 2 milligrams and this is 8 milligrams, somewhere around here, as we start to get that buprenorphine into the system, it starts to get on those receptors and we start to get that displacement. And so in lower doses, essentially what's happening is we're displacing the fentanyl that's in there, but we're not activating enough opiate receptors to sort of get us back to, so like when we turn the buprenorphine on, we're trying to turn that on, but this is dropping too quickly. So what we need more buprenorphine turned on as this gets shut off to sort of get those individuals back to a baseline of not having significant withdrawals. And so I always tell patients, if we're doing a conventional initiation where we give them small amounts at a time, that, hey, if you start to have precipitated withdrawals, the answer is more buprenorphine. You need to take more buprenorphine, because if you get more buprenorphine on there, then you can get more activation. And so really, really important to like notify patients of this ahead of time, because if they take buprenorphine and they take a little bit for the first time and they start to feel like crap, they're not going to want to take more of the medication. And so helping to educate them on the front end can be really important. I won't go into it now, at least with the time that we have. But again, a lot of the initiation methods, there's conventional and there's micro initiation, and probably the one we use most often now is a high dose initiation, where we have patients wait 6 to 12 hours from their last fentanyl use or their last 7-OH use, and then we give them 16 milligrams Suboxone all at once. So we give them a big dose of Suboxone, have them wait an hour, take another 8 milligrams of Suboxone, have them wait an hour, take another 8 milligrams of Suboxone, up to 4 tablets, which is above sort of the recommended dosing. But that allows us to sort of saturate those opiate receptors and sort of get them through that. And again, just a final knowledge check as we shut it down. What's the mechanism by which buprenorphine can precipitate withdrawals? Again, this high affinity for this opiate receptor displaces this agonist from the receptor, rapidly decreases the opiate effects, and the person experiences that as sort of a severe withdrawal. Now, again, the good thing about this, high affinity is once we get patients on this medication, it prevents them from overdosing. So this blockade is a really good thing. It's just something we have to work through with sort of the initiation of the medication. So drug-drug interactions, side effects, you'll have to read about those on your own if you're interested in them. And then I always talk about, the initiation options. Those are on there, but also Project Echo, and just how, hey, we're here to do education and we're here to be a consult service to people. And so if that's helpful for individuals, we always want to continue to put that before them and make sure they know that these trainings are available. We're happy to do them wherever it's helpful for you guys.
Awesome. Thanks so much, Ed. I didn't tell everyone this morning at the beginning of this training, but I called Ed about 10 minutes before we started and said, "Hey, Stephanie's been in a car crash. Can you jump on?" And Ed was ready to go. So I really appreciate you jumping on, Ed, and doing a great job with this talk. Let's see, one thing, Ed, can you send me those slides? We had one request for those slides, so I will include those slides in the email that I send out in about a couple hours from now. Yeah, there's a message in the chat from Kelly. Super glad she's okay. Yeah, Stephanie is okay. She's in recovery though. But yeah, thanks again for jumping in, Ed. The link to the evaluation survey is in the chat, and I'll also be sending that out with the email within a couple hours here. So thanks again, and have a great Friday, everybody.
Thanks, guys. See ya.